For our next talk, I would like to introduce our next speaker. Her name is Tanya Bardakjian. She is the Associate Director of Genetic Counseling and Co-Director of the Neurogenetics Program at Huntington's Disease Center of Excellence at the University of Pennsylvania. She received her Master's of Science in Genetic Counseling from Arcadia University and has over 20 years of experience in the field of clinical research in genetic counseling. She provides genetic counseling and genetic test coordination for a variety of neurological indications and serves as a resource to providers in the health system. She educates students, residents, and fellows on the field of clinical neurogenetics, and she has made multiple important contributions to the fields of clinical genetics and genetic counseling, which also includes participation in the discovery of novel disease-causing genes. She has served as a leader and member of several committees of the National Society of Genetic Counselors, including Billing, Licensure, and Reimbursement, Public Policy Committee, and Abstract Committee. She provides patient care in the Neurogenetics Clinic, the Huntington's Disease Center of Excellence, the MDA Clinic, Inherited Neuropathy Program, the Parkinson's Disease Center, and the ALS Center at Penn Medicine. Tanya, you have a lot that you're working with there.
Yes, thankfully we've hired 3 new genetic counselors to help.
That's a lot for you to take on all by yourself. I will let you go ahead and share your screen, and thank you very much for being with us today.
Good afternoon, everybody. My name is Tanya Bardakjian. Thank you for that introduction, Nicole. And I'm going to be talking overall about the genetics, genetic testing, and some family planning issues in the myotonic dystrophy space. I'm going to start with a really quick Genetics 101 background so that we're all kind of at the same page when we're talking about different options for genetic testing. So taking you back to Genetics 101, these structures on the left that kind of look like worms, they are what our chromosomes look like under a microscope. And our chromosomes are basically the packaging that hold all of our genes that are made up of DNA. And on the right, you'll see that we can actually put these chromosomes in pairs, and they're numbered 1 through 22. The 23rd pair are the sex chromosomes, or the gender chromosomes. 2 X's indicate a female biologically, and an X and a Y would be for a male. And we have 2 because we get 1 from our mom and 1 from our dad. So in the cell are the chromosomes. The chromosomes are made up of genes. Genes are made up of DNA, and each DNA is made up of actually these DNA bases, or letters as we call them. It has its own alphabet, our DNA, A, C, G, and T, and they line up to make certain words or recipes. So we kind of say in genetic counseling, the whole genome is the book, the chapters are the chromosomes, and each sentence is an instruction, and that's the gene. So you can find the gene, if you're thinking about it in your head, to be like a sentence. And you can have 1 letter changed in that sentence that can change the entire meaning of that sentence. So the gray cat ran down the hall. This 1 letter change changes it to the gray cat ran down the ball. So changes in your DNA might change the way a gene works or how it functions. So we're going to talk a little bit about inheritance. So we know that, for the myotonic dystrophies, they are autosomal dominant. That means that only 1 copy of each of the genes needs to be mutated. There's 50% risk to each of your offspring if you have myotonic dystrophy 1 or 2, because 1 of the 2 genes is mutated. So every time you have a child, either the mutation gets passed on or the typically working copy gets passed on. It is the same risk for males or females. This is not gender related, so it's not on those sex chromosomes. So there are many families where we can hear in clinic, oh, well, only the females are affected or only the males are affected. It might appear that way in certain families, but it is truly non-sex related in the myotonic dystrophy 1 and 2 space. If a person does not inherit the mutation, they cannot pass it on. And in DM1 and DM2, the mutation type is not 1 single letter difference, but it's a mutation known as an expansion, which I'll explain in a little bit. So for myotonic dystrophy 1, the gene is known as DMPK, and you get repeats of, remember I said the DNA has its own alphabet. In the gene DMPK, in a typical individual, we should have these 3 letters, C, T, G, repeated a certain number of times, and that's considered normal. It tells the gene, you got to this point, you see 20 repeats of CTG, it's time for the gene to turn off. But in mutations of this gene, you get CTG repeated too many times. Greater than 50 repeats of CTG is associated with myotonic dystrophy 1. We do see something called anticipation, where it can get worse or the repeat number gets bigger from one generation to the other. And in myotonic dystrophy 1, this anticipation or increase in expansion or repeats can be such that it gets so large it can cause a more severe clinical syndrome known as congenital myotonic dystrophy. So the repeat number can matter in terms of what it can look like symptomatically in the individual. So we know that with less than 38, it's totally normal. There is this gray space, sometimes known as borderline, of 39 to 49 repeats. And then we get to the truly affected range, 50 or more. Typically, we think of 50 to 150 repeats of CTG as the mild myotonic dystrophies. The classic would be 100 to 1,000. And then the more severe congenital type is associated usually with greater than 2,000. There is a lot of overlap and a lot of gray spaces, but this just gives us general overview information. What are we talking about when we talk about mild, classic, or congenital? You can see that with mild, sometimes all you might see is some myotonia and cataracts. With classic, you would expect to experience weakness, cataracts, some balding, cardiac arrhythmias. And then with congenital, you can get very severe hypotonia, which is poor muscle tone, and weakness and respiratory difficulties that occur earlier. So at a younger age, typically in the newborn period and in some cases prenatally. I highlight here that there's variability between types, between families, even within the same family. You can have some people more severely affected, and it's very difficult to predict what one individual will look like, even within the family, based on genetic test results alone. With myotonic dystrophy 2, we're talking about the CNBP gene. And here, instead of 3 letters being repeated over and over, it's what's called a tetranucleotide repeat, 4 letters, CCTG. And you get an affected individual with greater than 75 repeats. Myotonic dystrophy 2 differs from 1 in several ways, but one of the really distinct differences is that there is no congenital type with myotonic dystrophy 2. So a parent with myotonic dystrophy 2 or a CCTG repeat of more than 75 is not at risk to have a child with a severe congenital clinical picture. Again, you have this range of individuals. These numbers are really generally speaking and don't help. We usually say positive or negative with myotonic dystrophy, greater than we would repeats than we would expect, or less than. So what are the types of genetic testing that we might hear about or consider? Sorry, I just want to see if I can change the view of my slides so I can hide my picture and see my slides better, but okay. So with genetic testing, there's 3 different things we can think about. Diagnostic testing, that is a genetic test that's used to confirm a diagnosis that's suspected on a clinical basis. So somebody comes to a genetic counselor or a neurologist and says, I have myotonia, I have weakness, I have an arrhythmia, and we want to confirm whether or not I have myotonic dystrophy 1 or 2. Predictive testing is somebody who does not have any known symptoms right now, but they have a family history of a known genetic mutation, and they want to know if they inherited that mutation and will develop the symptoms at some point in their life. And then we can talk about reproductive testing or family planning testing. The individual knows that he or she has a mutation, and they want to know what their risk is to pass it on to their offspring. This can be done either through prenatal testing, where the individual couple that has an at-risk pregnancy can do prenatal testing while they're pregnant, or it can be achieved through something called preimplantation genetic testing with in vitro fertilization. And I'll touch on these in a little bit. Sorry. So what is the importance of genetic testing? Many people have received a clinical diagnosis of myotonic dystrophy, and as was alluded to a little bit in the previous talk, especially historically, the chart might be riddled with information on myotonic dystrophy 1, myotonic dystrophy 2, but the genetic test is very important. It is very important to confirm the diagnosis because the natural history and the risk to offspring is very different between 1 and 2. And although clinically they can look different, sometimes they don't. So having that actual genetic test report confirm 1 or 2 is very important for family planning options, for accurate diagnosis, for the natural history, and to provide optimal clinical care. So with family planning discussions, what are the things that one would talk about? It's the discussion on how and when to have children. Are there any implications for, will it change anything about how we decide to have children? How we will plan pregnancy? Is there a desire even for biologic children? Because that can change the way somebody might pursue family planning. Do you want to know your personal genetic status? Do you want to do testing? And everyone makes personal decisions based on their individual beliefs, desires, and where they are in their life. With any genetic testing, it's important to know, sometimes we have these thoughts that, insurance isn't going to cover it. What is the purpose of genetic testing? Is it blood or saliva? It's very simple now. There are many genetic tests, including myotonic dystrophy 1 and 2, that are covered by health insurances. Blood or saliva gives us equal access because DNA is the same in our saliva or our skin or our blood when we're talking about this type of inherited mutation. The results, where are they stored? They need to go in our electronic medical records so that our care providers can care for us appropriately over time as these symptoms develop and change. And they will make a difference for reproductive testing. I'm going to talk a little bit about the difference between prenatal testing and preimplantation testing, and I'm leaving a lot of room at the end for questions and discussion. So with prenatal testing, the couple is already pregnant. So let's say the dad knows that he has myotonic dystrophy 1. You can achieve genetic testing either through chorionic villus sampling or amniocentesis. CVS is done between 11 and 13 weeks of pregnancy, and it is basically taking a sample of the placenta, which comes from the same DNA source as what will become the fetus eventually. And what you're doing is taking a few cells from that placenta, and this can be done either through the cervix or through the abdomen, and a little sampling of the placenta is taken, sent to a lab, grown, and then the myotonic dystrophy 1 or 2 gene, whatever it is that the family is at risk for, can be analyzed, and you can get back the number of repeats and whether or not the fetus is affected. With amniocentesis, it's a little later in pregnancy, about 15 or 16 weeks, and what's being taken there are the cells around the fetus that are in the liquid. So just like we take a shower or bath, our skin cells fall off. Well, our skin cells are floating around in this amniotic sac. The main differences between CVS and amnio are the timing of the procedure. CVS can be done earlier. And then the second difference is that both have a slight risk for causing a miscarriage during the pregnancy as a direct result of this procedure itself, CVS has a slightly higher risk for miscarriage. They are both very, very, very rare, less than 0.5% chance to cause a miscarriage, but they're there. So that's why usually genetic counseling occurs when you're doing this. But what's very important is you must know the condition for which you're testing in order for it to be effective. And then the other option is something called preimplantation genetic diagnosis. So this is done with conjunction with in vitro fertilization. It's a test done on the embryo at a very early stage, 6 to 8 cell stage. And only those embryos without the myotonic dystrophy gene expansion are transferred to the uterus. So you know that, except with small possibilities, that the embryo that's being transferred is not going to be affected. So what is genetic counseling, and why would somebody seek a genetic counselor? Well, genetic counseling is the process of helping people understand and adapt to their medical, psychological, and familial or reproductive implications of a genetic contribution to their disease. It integrates interpretation of a family history to assess the chance of occurrence or recurrence of that condition. The goal is to educate about inheritance, various resources available, and research options. And then it provides counseling to promote informed choices and an individual's adaptation to the condition that's been identified for them or their family. We are healthcare professionals with specialized graduate degrees, and we are experienced in working in areas of medical genetics and counseling. We do focus on providing information and support to families who have members with a genetic disorder, who may be at risk for a genetic disorder. And we really aim to support and provide resource to other healthcare providers who might not really have good experience on how to order a genetic test, make sure they're ordering the appropriate test, make sure the patient understands the genetic test that was ordered. And that's really very important. So the goal of genetic testing and counseling is to make sure that the individual understands the benefits and limitations of that testing and to help manage the care long-term of that individual as well as the family members. So with that, I'm going to stop talking and see if anybody has questions or if we want to have a discussion about the various options for genetic testing.
And is there anything that, why would it occur more in other families and less in other families? Is there a reason for that?
You mean why do some people have more symptoms than others? Yeah, we don't know the reasons. There's probably what are called gene modifiers. Okay. So there's either other variants in our genome that impact the way a mutant gene works, so that some families will have more severe disorders than others, or each individual within a family can be very different. We don't know about lifestyle and exposures. We just haven't done enough studies. Mm-hmm. But we do know in all genetic conditions, there's variability. Some people are more severe than others.
Okay. Can a parent with DM2 have a child with DM1?
No. Mm-mm. You are at risk only for having a child with DM2. It does not change. And that's why it's very important to have genetic confirmation of your diagnosis.
When testing a child, is there a way to tell if they will have juvenile or adult onset?
So I want to go back to, because I was here for the first talk, okay. There was a question about, do we test children? Mm-hmm. So overall, the recommendation has been that we don't test children for adult onset conditions unless they have symptoms. Okay. With the myotonic dystrophies, there's a little bit of back and forth and debate because of the cardiac risk and the risk for some learning issues if it's not diagnosed appropriately. So if a child has any sort of symptoms or there's any concern, one should see a neurologist and a genetic counselor, and with appropriate counseling could consider genetic testing even in a child because they can be symptomatic. So with myotonic 1, based on the number of repeats, yes, we can predict, but we can't ever say absolutely. The larger the number of repeats in myotonic 1, usually the more severe the symptoms and earlier the onset.
Okay. Okay. Oh, this is genetic testing as good as getting a muscle biopsy? I've had several biopsies done in the past to find out what kind of MD I have, but do I need to get a genetic test done now that I'm 67?
So I'm biased. I think a genetic test is better. I think I have seen a lot of patients that have gone around with a clinical diagnosis, which is muscle biopsy, neurology exam for years, and then the genetic test disproves whatever it was. So I think that with any clinical trials coming up, with family planning for the family, it's important to know exactly which type you have. Now, if your child has been tested or someone in your family has a confirmatory genetic test, you can assume that that's the same for you.
Okay.
But I would prefer to have it for myself.
Okay. How can individuals without insurance coverage get access to testing when they have lots of family history of DM1 and appear to be symptomatic?
Yeah, that's difficult. For myotonic disorders are not usually covered. It is a very specific type of genetic test that has to be done. So the MDA does have some sponsored testing programs for neuromuscular disorders, but DM1 and 2 can't be captured with regular genetic testing. So I would recommend that if you can, reach out to an academic center if at all possible. Sometimes large centers like where I work might have I can't think of the word, sorry. Charity care. We might have charity care programs or can find ways to help with that cost. And there are a lot of online telehealth genetic testing companies now that provide genetic counseling and ordering, and they can also provide some financial assistance. But the testing for DM1 and 2 can be relatively expensive.
Okay. What percentage of IVF results in pregnancy success? Do you know that by chance?
I can tell you overall, the question is not pregnancy, but how many live births. And that's what you want to ask when you go to an IVF center. What is their live birth rate?
That's good to know.
The highest report is probably around 35%. And that might be changing. I'm not an expert in that space.
Can you talk a little bit more about the role of the MYOM1 gene? MYOM1. Does that ring a bell to you? Okay.
No, but I'll look it up and tell you in a minute. Go ahead.
If you do the CVS test, you have to have them look for DM. If you do the test but don't know it's in the family, will it show up?
Can you ask me that again, and then I'll go back to the other question?
Yeah,
sorry.
if you do the CVS test, you have to have them look for DM. If you do the test but don't know it's in the family, will it show up?
No.
Okay.
Well, I'm sorry. If you do the test and look for the gene for myotonic 1 or 2, yes, it will show up, but you have to tell them to look for that. There has to be a reason to look. So many people have had amniocentesis for Down syndrome, let's say. It's not going to pick it up unless the laboratory knows that that individual is concerned for myotonic dystrophy 1 or 2.
Okay. Okay.
And just to go back to MYOM1, it's a regulator. Yeah. And I don't know a lot about it. I just know that that's probably one of the modifiers that I was talking about. There are likely modifiers that affect the way each of these genes work. And it looks to me on real quick glance that MYOM1 is affecting the way DMPK works.
Okay. Does getting positive genetic tests for DM1 automatically make it more difficult to get life insurance?
Good question. Yes, if you have no symptoms.
Oh, okay.
Okay. For predictive testing. So we tell patients before doing predictive testing, if you have no symptoms and have never been to the doctor for that, but if you've already been to the neurologist and it's all over your chart that you have myotonia and muscle weakness, the genetic test isn't going to impact your insurability. Your medical records are. So it's a big misnomer. Your genetic test by itself is not the problem. It's having the disease that's the problem. So anytime you apply for life insurance and you are getting a medical clearance, you are signing a waiver for them to access your medical records. So they have access to all of your medical records, and you must be honest about your medical records. So if you've already been clinically diagnosed with a myotonic disorder, the genetic test is not going to be the problem with life insurance. It's your diagnosis. But if you don't have symptoms yet, and you know about your family history, unless they ask you about your family history, you don't have to say anything. And then that genetic test result would be considered a pre-existing condition for life insurance. Now, there's also one caveat. If you get life insurance through your employer, they're not allowed to ask. So employers, health insurance, there is no discrimination there. You're protected under GINA and HIPAA.
Okay. What is the most accurate genetic test currently available at medical practices? Are they all the same?
You mean for myotonic 1 and 2?
Mm-hmm.
Yeah, it's called Southern Blot. I mean, all the labs are using pretty similar methodologies.
Okay.
There's various laboratories.
Okay. Is there a known possibility that there are more variants than type 1 and type 2, such as a suspicion of type 3?
Yeah, good question. And probably. I mean, that's what's happened in so many disorders where we do genetic testing. We know someone has myotonia and we can't find their mutation. There are other myotonic disorders that affect the muscle channels, and maybe we'll find more later. But if you find one, that's the answer for your family.
Okay. And this person says they have DM1. No one from my family has any symptoms. There is a known history for this disease in my family. Could I be ground zero for this disease for my family?
Yeah, good question. It would depend on the number of repeats. Sometimes it gets bigger from one generation to the next. So it could be that mom had a borderline mutation and then it expanded, because it can expand from mom to child. The number of repeats can get bigger. And then we also see that some people are just so mild, they just never presented to care. So you can see what's called variable expressivity, where there are people with it in the family, they just don't know it.
Okay, interesting. Let me see here. If you have DM1, can you have DM2?
Usually no.
Okay. Sorry, I'm just trying to go through these.
That's okay, take your time.
I can. If you had DM1, can insurance cover the IVF and pre-implantation testing?
So it's very hard to get insurance to cover it unless your insurance already has a policy that allows for IVF.
Okay.
And it's very variable. There's no way to answer that question without knowing your insurance. So you should make an appointment with an IVF center. That initial consult should always be covered because it's a regular medical consult, and they will do some of that investigating with you with your specific insurance at the time that you're going to try.
Okay. Can transmission from father to child show greater repeats?
Typically, no.
Okay.
It's usually from mother to child.
Okay.
Typically.
As a child, I was tested, if my child was tested 21 years ago, is there any reason to be retested?
If they have an answer, no.
Okay. All right. And testing, I would just think though, testing, if you got something that was done years and years and years ago and you got an inconclusive result.
Yeah, if you have an answer that was conclusive, no, there's no reason to repeat it. But if there was some sort of, you didn't get a diagnosis, or you don't have that report, or it was, we're not sure, then, I would say speak to a genetic counselor to review that result and see if you need a new one. Okay.
That's perfect. Okay. Can you explain maternal gene expansion for DM1?
So when a mom has the DM1 mutation, let's say she has 100 repeats, for some reason in the eggs, because our eggs are part of our body, so all our cells have one copy expanded. The eggs, as they're getting passed on and they're replicating, the number can go up from 100 to over 1,000. That's what an expansion means. It can get bigger. And when it gets bigger, it can cause more severe disease.
Okay, interesting, okay.
So just because you have mild myotonic disorder doesn't mean your child will have mild myotonic disorder. It does not run true in families always. There are definitely some people more severe than others.
And an age range with progression will either be faster or slower. That's not anything to be indicative. Okay. Okay. Okay, just to go back real quick to another question about life insurance. If children have life insurance through their parents and get tested as children, would it affect their life insurance when they become adults if they have a positive result?
If they want to get new insurance, yes. But once you have insurance, you cannot get dropped from your insurance unless they require like medical checks every 20 years.
Okay. All right.
But I want to bring up one thing, and you know, everyone is afraid of life insurability, but remember that with some of these myotonic disorders, there's cardiac arrhythmias. So being tested and being monitored for that is a life insurance. We don't want to avoid finding out what we have when we can intervene and take care of ourselves better. So it's a fine line. There's a cost benefit to think about, but the possibility of not getting life insurance should not be a reason you don't pursue genetic testing.
Okay. And I just want to be cognizant of our time here. It's a little after 2. Does the Southern test provide an accurate repeat count?
Which one?
The Southern test?
Yeah, Southern blot is probably the most accurate. Yeah. It's very laborious, very time consuming, very expensive. And yes.
Okay. Okay. Do you see anticipation in type 2 as well as type 1?
Typically, no, not the same way.
Okay. Okay. And do you know what the anticipation risk in DM2 is?
We don't usually see anticipation.
Got it. Perfect.
Now, we do see difference in severity between one or the other, but it's not that it gets worse in the next generation necessarily.
Okay. All right. Well, thank you very much. This was really interesting. We got a ton of questions, so I appreciate you being here and thank you for your time today.
Thank you.